Είναι μεγάλη μου χαρά να υποδεχθώ την Dr. Diana Laura, η οποία είναι τριτοετής ειδικευόμενη στο Bascom Palmer. Είναι η τέταρτη ειδικευόμενη που έχουμε από το Bascom Palmer. Έχουμε συνήθως 1 με 2 ειδικευόμενους το χρόνο που επιλέγουν το Athens Vision για να κάνουν το International Rotation το οποίο έχουν. Έρχονται για 2 εβδομάδες μαζί μας. Μαθαίνουμε από αυτούς, μαθαίνουν αυτοί από εμάς και είναι μια πάρα πολύ ωραία συνεργασία η οποία συνεχίζεται και άρχισε πριν 3 περίπου χρόνια και ευελπιστούμε ότι θα συνεχιστεί. Και όπως φαίνεται στο μέλλον θα έχουμε και άλλους ειδικευόμενους είτε από άλλα πανεπιστήμια της Αμερικής, είτε από άλλα πανεπιστήμια. Περιμένουμε το Γενάρη και μία φοιτήτρια που τελειώνει στο Yale και θα έρθει μαζί μας για 1 χρόνο, η οποία θα κάνει μάθηση οφθαλμολογία σε λίγο καιρό και θα περάσει 1 μήνα μαζί μας τον Ιανουάριο. Okay, it is a pleasure to have with us Dr. Diana Laura, who is a senior resident at Bascom Palmer. Diana is a wonderful person. She's also an excellent surgeon, and she is so excellent in all respects that she was chosen to be one of the chief residents at Bascom Palmer. This is a very honorary position. A lot of people actually fight for that in the graduating class. So Diana next year will be a retina fellow, and the year after will be her 2nd year of retinal fellowship. She will also be the chief resident, which means that she will take care of most of the trauma cases and most of the undeserved population, really complex retina cases, and be responsible for the resident education as well. So she will present hopefully 3 cases with us and ask some questions in between so that we can all participate in the differential diagnosis. So Diana.
Thank you for the opportunity to be here today. Okay, so I'll start with our first case. I have no disclosures. Our case begins with a 72-year-old female who presented with left eye tearing and left lower lid retraction. She had no significant past ocular history. For purposes of forming a differential diagnosis, I'll withhold her past medical and past surgical history, and she's not on any medications. Her vision in both eyes was 20/25. Her intraocular pressure was normal. Pupils, confrontation visual fields, and extraocular movements were also all normal. And here we have a photo of our patient.
Ωραία, μιλάω. Ωραία, να μας πει ο κύριος Γιώργος Χαρώνης τι βλέπει στη φωτογραφία. In English or in Greek, whatever you prefer. I just asked for him to describe the picture.
Said that we have another great colleague, oculoplastic colleague in the audience, that's why. But I can start and maybe Thanasis can continue.
Okay.
Well, I cannot see the eye, so I take it that there is some eyelid retraction there, more on the left than on the right side. But I do see some significant mid-face fat atrophy, which is more noted on the left than on the right. And also there are some lumps and bumps under the eyes, especially on the left side. I don't know, I would like to palpate that to see if it's hard, if it's mobile, if it's painful. I have no idea from the picture.
Okay. So either you or Thanasis, what are you...
This is just detailing what he described already.
What are you thinking in terms of your differential looking at this patient?
I was thinking of to ask if she had a previous surgery in the lower lids, but that wouldn't be possible to explain the fat atrophy and the swelling. Based on her age, I would think of a lesion like a lymphoma. I would think like an accident or something.
Well, for the fat atrophy, I think, although that her age is not very, it doesn't go with it, but HIV atrophy is one, on the top of the differential in patients that have such severe facial atrophy, or, other rare things like Parry-Ramberg syndrome, but I would definitely do something to look at these lumps. I mean, feel them clinically and see what's going on with those.
Okay, so let's see.
All right, great. Yes, this is the differential that we came up with. So definitely the prior surgery or trauma with subsequent scarring, some sort of a Parry-Ramberg syndrome, lipoatrophy, and linear sclerodoma. So a little bit more about our patient. So 4 years prior to presentation at Bascom Palmer, she underwent mid-face augmentation with calcium hydroxylapatite dermal filler injection. So a little bit about dermal fillers. They're used for cosmetic tissue augmentation. Types of fillers include hyaluronic acid, calcium hydroxylapatate, polymethyl methacrylate, and autologous fat grafts. So after her dermal filler injection, she developed a painless nodule at the union of the zygoma and the maxilla and the soft tissues of her left cheek. And her CT scan looked like this, which revealed a 5 mm mass in this area. So what are some complications of dermal filler injections? Early complications involves hypersensitivity reactions and hematomas, as well as more devastating consequences such as emboli. And late complications can include granulomas, scarring, and abscesses. So our presumed diagnosis here was a granuloma, and her outside provider injected her with triamcinolone and 5-FU. Granulomas have been described after dermal filler injections, and they're from the aggregation of macrophages in response to a large foreign body that can't be phagocytosed, and this results in granulomatous inflammation. That's shown here. This is fibrovascular tissue with inflammation composed of foamy-filled histiocytes, foreign body, and giant cells, and this is an asteroid body on the bottom. Risk factors for the formation of granulomas include increased volume injected into the area, repeated injections, as well as the particle size, the particle surface smoothness, and the surface charge. The treatment of granulomas include intralesional steroids, intralesional 5-FU, antibiotics, excision, hyaluronidase if it's a hyaluronic acid injection, and systemic corticosteroids or allopurinol. So in our patient, unfortunately, the mass enlarged and it seeded to surrounding areas, and she underwent a biopsy with ENT, which actually revealed a low-grade myofibrosarcoma. Myofibrosarcomas are malignant tumors of myofibroblasts. They can be subdivided into low and high grade, with the low grade being an infiltrative tumor mostly in the head and neck that rarely metastasize but can recur. The high-grade tumors are pleomorphic myofibrosarcomas, and they can resemble malignant fibrous histiocytomas. And this is actually pathology from our patient, which reveals spindle cells. And this is an SMA stain, a smooth muscle actin stain that highlights those cells. So neoplasms are very rarely described after dermal fillers. There's only a few case reports in the literature, so I'll go through a few of those. In this patient, a 72-year-old developed a palpable cheek mass 50 years after a silicone injection, and the biopsy actually revealed an extranodal marginal B-cell lymphoma. And the authors postulate here that the fillers actually caused a chronic inflammation that triggered lymphoma development. In this report, an 83-year-old HIV-positive man had biopsy-proven infiltrating basal cell in the right cheek, and he had underwent polyalkylamide injections for lipoatrophy from heart treatment 7 years prior. And the authors note here that the radical resection was actually really challenging because there was distortion of the normal architecture from the filler. In this case, a 27-year-old man underwent a collagen filler injection, and he developed a severe granulomatous reaction at the injection site. And then 1 month later, he developed cutaneous nodular lesions, and the biopsy actually revealed a keratoacanthoma. Now, granulomas can masquerade also as neoplasms. And in this case, this was a 56-year-old female that had facial nodules for 10 years, and she had a history of filler injections 20 years before. Neurofibromas were what was suspected clinically, but her biopsy revealed foreign body granulomas. So how do we make the diagnosis? MRI can definitely help to differentiate between granulomas and neoplasms. Usually there's an area of hyperintensity surrounded by a hypointense capsule, but most important, biopsy. So our patient's sad story continues. She had a resection of the cheek twice because she had positive margins after her first resection with ENT. She underwent an autologous fat transfer for volume supplementation after these surgeries, but the fat graft failed, likely due to poorly vascularized tissue, and she actually developed a draining fistula in this region. She had loss of the left cheek contour with adherence of the skin to the maxilla, a negative vector, anterior lamellar deficiency, and this all resulted in the lower lid retraction that you see here. So what are some of the next steps for this patient? Extensive conversations were had regarding some of the surgical options, which would involve some sort of a combination of a spacer graft and maybe a lateral tarsal strip. But our problem with her was the mid-face descent. So you could consider some sort of a cheek augmentation to help lift the lower lid with a fat graft again, but given her poor response the first time, her prognosis was very guarded. And she ultimately elected not to undergo any other surgeries. So in conclusion, dermal fillers can provide volume restoration in the face. Granulomas are rarely seen after cosmetic filler injection. However, malignant tumors can mimic granulomas, and careful investigation is crucial in order to ensure appropriate diagnosis and prevent devastating sequelae such as this. Here's my abstract and my references. Thank you.
Great, thank you. Any comments or questions before proceeding to the next case? Okay, so let's go on. Let's hear the second one.
Perfect. All right, so case 2. No disclosures. So we have an 89-year-old man that presented with left eye redness and mild irritation for 6 years. He denied any pain or vision changes associated with this, and he can't say for sure if the appearance changed over this time, but he was referred from an outside provider for pterygium excision in the left eye. So he had no previous ocular surgery or trauma, and his past medical history is significant for squamous cell carcinoma of the skin and then surgical history for removal of this squamous cell. And he's a non-smoker. So examination disclosed visual acuity of 20/40 in both eyes. His intraocular pressure, pupils, EOMs, and concentration visual fields were normal. And this is our photo.
Okay, before I call on someone, would someone like to describe what we see here?
I have 2 other photos, if that helps.
Anyone? Okay, Mr. Anastasios, will you describe what you see here?
So it seems that we have a circumscribed lesion here that involves the corneal margin that starts from the limbus area, extending onto the cornea also. And what I would like to see clearly if it's movable nodule at this point.
Okay, good. And you see the feeder vessels as well, right?
Okay, great. And just to note, the posterior segment examination was only remarkable for some RPE modeling in the macula.
So what are you thinking?
So definitely you're going to think about the neoplasm here in this situation. We just had a case that Dr. Vadas opened as we was in Ophthalmology, and that's going to be talking about differential as well.
Could it be a benign lesion?
Yes.
Like,
With feeder vessels like this, with a history of it's growing for how long now?
It was 6 months.
6 months. Well, yeah, I mean, you would describe it, of course, you have to rule out malignancy, so you're going to have to do, as you pointed out before, here, biopsy first.
okay. Well,
You
like,
could.
Great. Yeah.
Okay.
So just stratifying
what?
it.
Sorry?
Yeah.
Yeah, that's actually in the differential. That's correct.
Perfect. Yeah. So
Yeah, so you can go ahead.
yeah. So benign lesions would be like a papilloma or hemangioma, and then the malignant lesions we would worry about and have to rule out include squamous cell, lymphoma, or Kaposi's. So how do we differentiate between these entities, specifically a papilloma versus an OSSN? Because both can have a papillomatous appearance, both can have abnormal blood vessels, and both are epithelial. In general, though, kind of what you were saying earlier, the papillomas have a more pedunculated and more mobile appearance to them. And OCT, of course, can be very helpful here. In instances of a papilloma, we have a thickened epithelium, whereas in an OSSN, the epithelium might be thickened and hyperreflective, but you also have this abrupt transition. So what about some of the other entities, just briefly going through them? So hemangioma is also mentioned. This is a round, like very well circumscribed red lesion. A malt lymphoma, for example, would be subepithelial, but can look something like this. And then Kaposi's sarcoma is usually raised and has more of like a purple hue to it. So our patient actually had a conjunctival papilloma. And in this talk, I'll discuss some of the features of the papilloma and the epidemiology, the relationship to the human papillomavirus treatment, and then I'll end with the use of the HPV vaccine. So clinical features of conjunctival papillomas: it's a benign epithelial tumor. It has hairpin vascular loops. It's usually exophytic in its growth pattern. And there's mixed reports of the most common location, but one thing that seems to be sort of decided is in children, it's most commonly seen in the inferior fornix, but in adults it can kind of be anywhere. Biopsy does help. You'll see acanthotic epithelium overlying a fibrovascular core. Who gets conjunctival papillomas? So both children and adults, but the most common people who get it are 20 to 39 years of age. There's a male predominance. In terms of its relationship to the HPV vaccine, so the HPV vaccine is a double-stranded DNA virus. There's over 80 subtypes that have been identified, and HPV encodes E6 and E7 oncoproteins, which end up resulting in cell cycle activation and tumor proliferation. HPV can be subdivided into low and high risk. The lowest strains include subtypes 6 and 11, and this can cause genital warts and low-grade intraepithelial lesions of the uterine cervix, as well as recurrent respiratory papillomatosis. High-risk strains include 16, 18, 31, and 33, and this is the cause of uterine cervical cancers and other carcinomas. What's the relationship here? So the frequency of HPV DNA in conj papillomas varies in the literature, but is somewhere between 50 and 100%. And it's most commonly associated with the low-risk subtypes. Interestingly, if we look at the types of papillomas that cause cutaneous, conjunctival, and genital, we see that the overlap really lies between the conjunctival and the genital papillomas. So what is the mechanism here? In infants, the HPV is thought to be inoculated into the conjunctiva during vaginal birth, whereas in adults, it's probably self-inoculation. And the peak incidence of conjunctival papilloma is actually analogous to the peak incidence of genital HPV infections in both men and women. So this study actually looked at the relationship between the cutaneous and the genital and the papillomatous strains of HPV in 14 men and 8 women that had genital warts, and they took cytobrush samples of their fingertips. And what they found here was that 9 men and 3 women were found to have HPV on their fingertips. And in 5 of the men and 1 of the women, it actually was the exact strain of the conjunctival papilloma, which leads us to believe that self-inoculation is possible. So how do we treat this? Most commonly, excision and cryotherapy. Mitomycin C is also used, oral cimetidine, topical interferon, and then other less commonly used treatments include anti-VEGF and photodynamic therapy. So how do you decide between these? In excision and cryotherapy, a no-touch surgical excision with a double freeze-thaw cryotherapy is used. And this is good for the larger, more pedunculated lesions that are very symptomatic. It's cheap if the patient's insured, but there is a risk of recurrence. Mitomycin C has been reported in cases of recurrent conjunctival papilloma. It's applied after excision, but the side effects of mitomycin C can include irritation as well as limbal stem cell deficiency and canalicular stenosis. Oral cimetidine is commonly used for peptic ulcer disease, but it's been reported in papilloma recurrence as well. And the thought here is that it's immunomodulatory, so it enhances the immune system. The side effects, though, of cimetidine include headaches, dizziness, and drowsiness. Interferon has anti-tumor action as well as antiviral action, and it's thought that the amount of the virus is so reduced that the host's immune system can prevent recurrences. And it's been reported as both an adjuvant and a primary treatment. In this report of 2 patients with biopsy-proven conjunctival papillomas, interferon was used as the sole therapy, and in 1 patient, there was complete resolution at 3 months with no recurrences seen 40 months post-treatment. And in the second patient, there was complete resolution in 6 weeks, and no recurrence was seen at 18 months post-treatment. There's no significant side effects of interferon, but it is expensive, and it can take a long time. In our patient, we did use interferon. So this is him before treatment, 6 months of treatment, and then this is 9 months of treatment. So a little bit more about the HPV vaccine. So Gardasil was initially a quadrivalent vaccine in 2006, and it was initially against strains 6, 11, 16, and 18. A 9-valent vaccine was released in 2014 and covers these subtypes. And it's used to prevent transmission in those vaccinated before exposure. Who should receive the vaccine? So it's newly FDA approved for patients up to 45. That's as of 2018. Before that, it was patients under 26. For patients who are 9 to 14, it can be given in a 2-dose schedule, and those over 15 years of age get 3 doses within a 6-month period. Now, they've just studied the use of HPV vaccine in recurrent papillomas really in the respiratory system in recurrent respiratory papillomatosis, so I'll go through a few of those really quickly. This was a retrospective chart review of 20 patients that had recurrent respiratory papilloma and had Gardasil as part of their treatment. The standard of care at that time was surgical excision. And they found that they had an increase in intersurgical interval after vaccination, and 40% experienced complete remission. But just to note, in this study, all patients were receiving or had tried other adjuvant therapies also, so having a causal relationship here is a little bit difficult. This was the first reported study of Gardasil titers in men over 26 years of age before it was FDA approved for patients above 26. And it was injected into 12 men that had HPV-positive laryngeal papillomatosis. Their serum antibody titers were very low prior to vaccination and rose significantly in all of them after vaccination. And they postulated that the natural antibody production capacity of patients that have the HPV infection is low, so that leads to the persistence of HPV infection and recurrence. So, therefore, could the production of HPV antibodies with the Gardasil injection inhibit post-operative recurrence? So given conjunctival papillomas have over 10% recurrence rate with just excision and cryotherapy, and antibody titers after vaccination are higher than after a natural infection, should we urge all of our patients to be vaccinated? So in conclusion, conjunctival papillomas are common benign neoplasms of the conjunctiva. There's a strong relationship between HPV and conjunctival papilloma. Topical and systemic and surgical treatments have all been employed previously, and the HPV vaccine may be useful in preventing recurrence. That's my abstracts and my references. Thank you.
Okay, thank you. So I'll make a couple of comments for this case. So the reason we thought this was a papilloma was because of its appearance and the way it looked on OCT. So the appearance, it did have the feeder vessel, it was at the limbus like an OSSN is, but it had those tiny little vessels all around. These are very, very, very papillomatous. A papillomatous OSSN doesn't look like that. And also we had the OCT. Let's say you want to do a biopsy and to determine whether this is neoplasia or papilloma. You can do an incisional biopsy where you take a small piece, you send it to the pathologist, and then you get the diagnosis. Or you can do an excisional biopsy where you remove the whole thing like it was an OSSN with cryotherapy, big margins, all of this. The issue with the papilloma, if you do that, so if you do an incisional biopsy, you will be seeding the virus in other areas of the conjunctiva. So you definitely need, after the incisional biopsy, once you get your diagnosis, this is a benign papilloma, to use topical interferon or oral cimetidine, something topically for a long time, like 9 to 12 months, to cover the whole ocular surface. Otherwise, you're going to start getting papillomas in other areas. If you do an excisional biopsy, the way and the reason you have a high recurrence rate is the same, because you're seeding virus in the area, even if you do a no-touch technique. So you may get papillomas in other areas postoperatively. So either you have to use interferon postoperatively, or intraoperatively, the way you excise the papilloma is by freezing it. So you freeze the whole lesion and you cut it while it is frozen. And that way the virus doesn't spread on the surface. I hope that was clear for everybody. If you have any questions or comments before we proceed. Anyone? No? Okay, so let's do the last case.
All right, last case. Okay. So this is a patient who presented with left eye pain. This was a 32-year-old man who presented to our emergency room at Bascom Palmer with a 1-month history of left eye pain associated with blurry vision and conjunctival injection. He had no known past ocular history, and I'm going to withhold his past medical history as well as his medications for purposes of a differential diagnosis. So on exam, his visual acuity was 20/20 in the right eye and 20/60 in the left eye. His intraocular pressure was normal. His pupil was sluggish on the left, and EOMs and confrontation visual field were normal. I don't have a photo of his anterior segment, but his left eye had conjunctival injection, pseudodendrites with corneal edema and haze, and he had trace anterior segment cell. This is a photo of his right eye, which appeared normal. And in his left eye, the haziness is actually from the cornea. It's not a great photo here, but I'll have to just tell you that there was kind of a circular area of retinal whitening along the superior arcade. It's very difficult to see in this photo. So
Okay.
what would be the differential diagnosis of a circular area of retinal whitening?
Exactly. So differential for a white spot in the retina in this context of an inflamed eye. Any of the retina specialists wants to take a stand? Okay.
In my mind, it's infectious or infectious, or most likely infectious, because it's a solitary lesion, in the retina. You have to rule out an infection. So, and then, inflammatory causes. You can, sarcoid. You can start, something viral. HSV, VZV. Then something like tuberculosis, and then inflammatory causes like sarcoidosis, some autoimmune,
In my mind, in general, what I try to do, I try to be as descriptive as possible. A white lesion, is it, a white lesion superficial in the retina? It could be retinitis, or it could be an infarct. It could be something ischemic, could be something like a cotton wool spot. Just descriptive. Now, because this will, kind of change the way I'm thinking, just by describing a white lesion on the retina. I also like to know whether there's any more deeper lesions, choroiditis, is there inflammation in the vessels around it, is there inflammation in the vitreous, is there inflammation and so forth. So, just by describing a white spot in the retina, it could be retinitis, or it could be just vascular infarct or some kind of ischemia. Now, obviously in this case, we have inflammation, we have anterior segment inflammation. I'm not sure what the vitreous is like, but you can't really estimate what the vitreous inflammation is because of the cornea.
Right, exactly. Yeah.
I would like to know whether there are any other lesions in the far periphery or anything like that.
Sure.
And obviously then, the first thing, as George said, you need to rule out infection because that's a case. A young guy, you never know. Obviously, his social history and medical history is probably something. There's something there because you withheld it. So.
Yes, exactly. No, I agree completely. So just as you said, a singular white lesion in the more superficial retina could be a cotton wool spot. Viral retinitis was certainly on our differential, especially given some of the anterior segment findings. Other infections such as toxotuberculosis, syphilis, and an endogenous endophthalmitis can cause a white lesion, malignancy, as well as something inflammatory like sarcoid.
So you got all of them between the two of you. Yeah. Let's go on.
Oh, okay. So a little bit more about our patient that I didn't mention earlier. So he had vesicular lesions on his forehead 8 weeks prior to presentation. He was treated with acyclovir 800 milligrams 5 times daily for 10 days. The rash resolved, but then he developed some stromal haze in the cornea. He was treated with PRED, and then he was lost to follow-up until he presented to us with this focal area of retinal whitening. So once we saw this, we did a vitreous and an AC tap, and we injected antivirals, because that was our highest on our differential. And our PCR results were positive for VZV, and he also underwent blood work, and he was HIV positive with a CD4 count of 21. So he was started on Valtrex, and he received 6 intravitreal phoscarnet and ganciclovir injections in total. And then he was lost to follow-up again. And then he returned for an appointment 5 months later, and he hadn't started heart treatment, and he had self-discontinued Valtrex at some point. And so this is what he looked like 5 months after initial presentation. I don't know if anyone needs to describe this or
I think
not.
now it's more obvious what is going on, right?
Yeah.
Yeah, there's someone in the back. Yeah. There's someone in the back who wants.
In the presentation, you said that the patient has pseudodendritis.
Pseudodendrites, exactly. Yes, exactly. Yes, exactly.
Exactly.
Again, what is relatively atypical, though, is that, the classic teaching is that, it doesn't necessarily, you have corneal involvement of the zoster virus, and you usually do not have simultaneous involvement of the retina.
Right.
You usually get isolated retinal necrosis, but you don't usually get, anterior segment corneal involvement. So, were both AC tap and vitreous tap positive for VZV?
Good question. I believe yes. but I'm not 100% sure.
I'm not quite sure about that, but I guess if you do have corneal involvement, you probably could expect to have the AC tap being positive. I'm not quite sure about that.
That's a great point.
Even though the AC sensitivity is very good for acute retinal, for horn or acute retinal necrosis, but in the setting of anterior segment inflammation, I'm not sure whether that's necessarily this cotton wool spot. I could call it the cotton wool spot and follow it just being HIV retinopathy.
Sure.
So
Sure.
obviously this is not HIV.
No, but that's why it was so interesting that it was concurrent.
Both anterior and posterior segment.
Sure.
He was very immunosuppressed, so maybe that's why.
Absolutely. Yeah, so now here he has bilateral retinal necrosis, and he has some areas of hemorrhage, and then in the left eye, actually, he had some blurring of his optic disc margins as well. So we diagnosed him with progressive outer retinal necrosis, or PORN, and we actually admitted him to our affiliated inpatient hospital, given his poor compliance and clinical worsening, and he received IV acyclovir, and we did intravitreal injections every 2 days. So in this talk, I'll discuss a review of PORN clinical criteria, some of the treatment and the disease course and complications. So this was first reported by Forrester in 2 patients with AIDS in 1990. It's a distinct form of retinal necrosis in immunocompromised patients. It is most commonly seen in AIDS patients, but it has been reported in patients with non-Hodgkin's lymphoma as well as transplant patients. The etiology is most commonly varicella zoster virus, but herpes simplex has also been reported as a cause. On electron microscopy, you can see enveloped and non-enveloped particles that measure 80 to 100 nanometers in diameter, which is classic for a herpetic infection, and this is in the nuclei of the photoreceptor cells. The clinical criteria were sort of solidified by Angstrom in 1994 in a retrospective review of 38 patients. And they settled on multifocal lesions with deep retinal opacification without granular borders, the lesions located in the peripheral retina with or without macular involvement. It rapidly progresses, and there's an absence of vascular inflammation, and there's minimal or no intraocular inflammation. This table just differentiates between the 3 types of viral retinitis. I just want to draw your attention to the fact that in PORN, patients are immunosuppressed. It's very frequently bilateral. There's usually no or very minimal vitritis. Retinal detachment is very common, and progression is rapid. And here's some photos kind of illustrating some of these differences. So this is a case of ARN, and you can see that there's areas of confluent retinal whitening with a lot of overlying vitritis. On FA, you can see an occlusive vasculopathy. This is PORN, minimal to no vitritis seen here with areas of retinal whitening and kind of a confluence of it in the macula. And this is CMV with perivascular inflammation and a frosted branch angiitis pattern. So the treatment historically had been systemic antivirals, and some studies have reported that combining these systemic antivirals can yield better outcomes than just acyclovir alone. The use of intravitreals with intravenous antivirals has been reported. A lot of the time it's in case reports with mixed outcomes and limited follow-up. But in this study, there were 7 patients with AIDS and PORN, and all patients received intravenous ganciclovir and foscarnet. And then 2 patients received intravitreal ganciclovir and foscarnet, and 5 patients received intravitreal ganciclovir. And what they found was almost half of the treated eyes achieved a final visual acuity of 20/80 or better. Only 18% progressed to no light perception. There was no progression of the disease while undergoing intravitreal treatment. And so their preferred regimen was intravenous ganciclovir and foscarnet 3 times weekly for 2 weeks, and a maintenance therapy, intravitreous, I should say, and then a maintenance therapy of 1 to 2 injections weekly as indicated. This was one of the largest studies performed. It was a retrospective interventional case series. This was in 50 eyes, and they were treated with intravitreal ganciclovir until regression was achieved or until NLP vision was reached. 13% of eyes did progress to NLP, but this was compared to 60% in the study by Angstrom that lost light perception that was done with just systemic antivirals alone. In general, the disease course has a very poor prognosis. Optic neuropathy can be seen in almost 1/5 of patients, and retinal detachment is very common. Detachment rates vary, but are somewhere between 50 and 70%. There's a significant trend to worse vision following a detachment, even if successful reattachment is achieved. And the timing of the detachment is kind of twofold. Most detach within the first few weeks, but some can detach months later. The pathophysiology for the early detachment is full-thickness necrosis that leads to holes through the inner and the outer retina, and this leads to the rhegmatogenous detachment. In some of the late retinal detachments that's been described more in the CMV literature, it's thought that there's pathologic vitreoretinal interface changes that cause traction and elevation with retinal breaks. Prophylactic laser has been reported with variable success. It is a little bit more successful in ARN than in PORN. In the study by Engstrom, there was a 93% detachment rate in those who had received prophylactic laser. In another study, it didn't prevent macular detachment, but the authors think that it slowed it. And in the most recent study in 2002, 20% of retinas that were treated with laser demarcation detached. So why doesn't it work? So it's thought that subretinal fluid probably crosses the laser demarcation line, or the retina that is already necrotic just has a remaining very thin inner retinal layer that has elastic properties that can contract and form traction and then breaks. Or it's that it progresses too rapidly that the laser doesn't have a chance to create areas of adherence. So back to our patient. So 10 days after we admitted him to the hospital for systemic antivirals and intravitreals, he developed a retinal detachment in the left eye. So he underwent a buccal with vitrectomy and oil. And then 1 month post-op, he was count fingers at 14 feet. Then he underwent a retinal detachment in the right eye, and he underwent a buccal with silicone oil. He developed cataracts in both eyes. He underwent a phaco IOL and a silicone oil exchange in the right eye. He had a cataract extraction and silicone oil exchange in the left eye, but was actually left aphakic with the anterior capsule left in place to prevent oil from moving into the anterior chamber. But actually, his final vision was 20/30 in the right eye and 2800 in the left eye. And he is currently on maintenance treatment with Valtrex and is compliant with medication and is doing fairly well. So in conclusion, PORN is a form of retinal necrosis seen commonly in patients with AIDS and commonly caused by varicella zoster virus. Some of the key characteristics include deep retinal involvement, rapid progression, and minimal inflammation. The treatment typically consists of a combination between intravitreal and systemic antiviral therapy, and in general, patients have poor vision with 50% of affected eyes progressing to retinal detachment. That's my abstracts and my references.
Thank you. Thank you. That was excellent. Any questions or comments on the last case?
I have a question.
Mm-hmm.
So how did the cornea clear?
Sorry?
Because the
Yeah.
view to the back...
Got a lot better, yeah. His cornea ended up clearing with another treatment course of Valtrex, and he was continued on pred.
And the vitreous was clear in
The
the
vitreous was clear.
It was always clear?
It was always clear, yeah.
Okay.
Okay. Very good. Excellent. Thank you for 3 great presentations.
Yeah.
Thank you.
Thank you.